Okay, so today we are going to talk about irritable bowel syndrome as it relates to FODMAPs, diet type of FODMAPs, gluten, and rifaximin. I'm Dr. Martin Rutherford. I am a certified functional medicine practitioner, and my colleague is
Dr. Randall Gates. I'm a board certified chiropractic neurologist as well as being a chiropractor.
I was going to say we were both chiropractors, and I'm a chiropractor since the late 70s. And I understand that you're going to be spared the demand of watching us today because apparently we have lost our visual. We've lost the video aspect of this. So this is going to be strictly a verbal podcast-ish type of a presentation. And we may redo this later if the demand is there that you need to see us while we're doing this. This is a very important subject on gut problems. Okay, and for those of you who are not familiar with what we do, we have combined the disciplines of chiropractic, but more importantly, functional neurology and functional medicine to be able to put together a paradigm for chronic pain in which we have developed a chronic pain practice. We treat fibromyalgia and peripheral neuropathy and chronic fatigue and restless leg and dizziness and vertigo and balance and all kinds of stuff. Okay. And the gut, the small intestines and the large intestines specifically, is really kind of the center focus of the great part of what we do, both functionally and neurologically. So there are so many different understandings out there of the gut. I have patients that come in to me regularly. I do the intakes here and I do the initial screenings of patients, and people will come in and let me know what they're doing for their gut. Today, a little bit different than 5 years ago. People are trying the gluten-free diet. People have all seen the commercial that says 70% of your immune system is in your gut, and they're all taking probiotics. And for the people who are showing up here, they're not working. People come in and talk about other different diets. What is it? The SDS diet, SCS diet,
SED diet,
SED diet, and the FODMAP diet is one of the diets that we're going to talk about today, that Dr. Gates uses in selected patients relative to gut function and rehabilitating the gut. In our world, you don't rehabilitate the gut in any of these chronic problems. You're not going to get any type of a long-term response, and it's going to limit the initial response that you get to some degree. So let's talk about the infamous and all-present irritable bowel syndrome. And I say that because most people that come in here who have a bowel problem, unless they've had a colonoscopy that has shown they have diverticulitis specifically or something like that, have been diagnosed with irritable bowel syndrome. So I'm going to defer to Dr. Gates for the criteria, the definition of irritable bowel syndrome, and we'll just go from there.
So yeah, it's a very prevalent condition. Estimates range from 10 to 15% of the American population. So ballpark figures, that's about 30 to 45 million people. I have seen other practitioners cite 60 million Americans having IBS. However, I haven't seen those statistics. So.
I was going to say, it doesn't seem possible that it could be that small based on what we see anyway.
Yeah, we see a lot of it. So in essence, there are a lot of people running around in this country with bowel problems, as we euphemistically say commonly. You know, everybody's stressed out, everybody's drinking their Starbucks in the morning, they're eating junk throughout the day. And then, you know, it's not a big surprise why a lot of us have these bowel conditions. So IBS is very, very prevalent. Irritable bowel syndrome is basically diagnosed by this thing called the Rome criteria. I think it's just important that we acknowledge it because this is how gastroenterologists put a label on you. In essence, they have to make sure that you don't have something like colon cancer or celiac disease, which is where the immune system attacks gluten and kills the gut, or a condition like Crohn's or ulcerative colitis. But once those have been ruled out, then if you have basically 3 days per month in the last 3 months where you've had pain and discomfort, and then you also have at least 2 out of the 3 symptoms where your symptoms improve with defecation, which means you have a bowel movement and you feel better, that aha feeling. Or the onset of these bowel symptoms and discomfort is associated with a change in stool frequency. So now you're going every other day, or maybe you're going 5 times a day. And then there's also a change in the form of the stool. So there's a tendency with IBS patients either to go towards constipation, go towards diarrhea, or to alternate back and forth between the two. So that's really how IBS is diagnosed. And as Dr. Rutherford said, we see a lot of it. It's almost rare if we have a patient come into this clinic who doesn't have some
That pretty much covers every bowel symptom.
Of IBS.
Yeah.
Yeah. And then we'll delve into some other aspects like SIBO today, which can be associated with IBS, can also be independent of IBS.
Yeah, and again, as Dr. Gates said, it's unusual for us not to see someone with a gut problem. If somebody comes in here and we have a little brief intake form and they haven't circled digestive bowel problems, I'll just automatically ask them, are you sure that you don't have constipation, diarrhea, bloating, frequent, no, always say, or acid indigestion? They'll always say yes. I didn't think, I thought that was normal.
Yeah, exactly. That's normal to have 6 bowel movements a day.
But I thought it was normal to have a bowel movement once a week, because I have it every week, so I mean, we make a little light of it, but it's just interesting how out of touch with our bodies we can get. And in developing the algorithms that have been developed here, or the protocols, whatever you want to call it, the paradigm for treating chronic pain, everything with us starts with the gut. So when Dr. Gates says we see this frequently, you're almost not going to show up in our office unless you have some sort of a bowel issue. And so there's been a tremendous amount of investigation and research done in the field relative to gut problems. And I think Dr. Gates is our research and development department here at this office. And I think he's probably reviewed all of that research and done a little bit of his own, because it's just been so important for us to get the bowels correct, to get anything else. I don't care whether it's peripheral neuropathy or fibromyalgia or migraines. I don't care what it is an important piece of that. So let's talk a little bit more about irritable bowel syndrome, and better known as IBS, and what causes it. What are the things that cause IBS?
So commonly people will talk about food intolerances. So when I say people, that will be gastroenterologists will discuss this too. So in essence, most IBS patients, about 2/3 of them will report that they eat a certain food and they feel worse. And so throughout history, gastroenterologists have recommended IBS patients to keep like a food log and see, which foods may be provoking your symptoms. However, we're now realizing that that can be upwards of 30 to 40 different foods, so it can be difficult to discern what foods are actually doing that. There's been great discussion about gluten, and we have gluten in the title of our broadcast today relative to IBS, because it's come under great scrutiny. And so here's where we go off on a tangent. And so this is relative to the food intolerant aspect.
Okay.
In essence, there's this diagnostic entity termed non-celiac gluten sensitivity. It really came to fruition in 2011 when a group of gastroenterologists got together and said, all these patients are reporting back to us that they feel better being off of gluten. And we don't have a lab test for this condition, yet they seem to eliminate gluten from their diet. They feel better. They introduce gluten back into their diet. They feel worse. And so this is a phenomena, and we're just going to put a label on it called non-celiac gluten sensitivity. However, as time has gone on, there's this group out of Australia that originally validated it. The lead researcher's name is Peter Gibson. And then he did a follow-up study where they basically put people on a low FODMAP diet, people with IBS. They put them on a low FODMAP diet for 2 weeks. And we're going to discuss what FODMAPs are, but just know that they're foods that can be associated with IBS. And then after this 2-week period, this group either unknowingly received basically gluten in high doses, low gluten and dairy proteins, or basically gluten-free products. And what they found is that those who consumed gluten and dairy products had a worsening of their symptoms again. From that, the researchers concluded that gluten is not the cause of IBS, which I think is jumping to a conclusion, because within research, we always want to say there's one thing that causes this condition. However, what is not acknowledged in this paper and what is not acknowledged in all these mainstream media resources now that are citing that this non-celiac gluten sensitivity is not real based on this one research study, basically. Nobody is talking about the fact that gluten did make these patients' symptoms worse when they ate the gluten with the dairy protein. There's a reason for that, and we're going to explain that. So gluten can be an issue, and with non-celiac gluten sensitivity, new data is coming out, in essence, demonstrating that those who have non-celiac gluten sensitivity, they have severe leaky gut syndrome.
And just in case there's somebody out there who doesn't understand, gluten is closely connected to celiac. Since 1950, the only thing that gluten was connected with, well, I don't even think gluten was connected with celiac until just recently.
I think it was acknowledged,
but
at 2000 it became very...
So basically the understanding was the only people who needed to be off of gluten were people who actually created an immune response in their gut called celiac. Okay, and so these doctors were looking at a ton of people who were not diagnosed with celiac, but they got off of gluten and they felt much better, and they ate gluten and they felt terrible.
Exactly.
So, yeah.
And so relative to this diagnostic entity term, non-celiac gluten sensitivity, one of the things they're finding is that when those individuals with non-celiac gluten sensitivity eat gluten, their intestines start to, basically your intestinal cells, and we did a whole broadcast on leaky gut, so go back and watch it. But the cells of your intestines should be tightly bound together all the time. Sometimes they'll separate a little bit to allow nutrients to absorb, but not a lot. What they're finding is that when gluten is consumed for a non-celiac gluten sensitivity patient, the intestinal cells open up significantly. In fact, as much or if not more than a celiac disease patient. So gluten can be causing problems with the gastrointestinal tract for these patients. Now, gluten may not be the only problem food for an IBS patient, but what they're finding more specifically with those who have gluten intolerance is that the gluten triggers neurological symptoms, namely depression and things like neuropathy and lack of balance. So one of the postulated mechanisms is that when gluten is consumed in a gluten-sensitive patient who doesn't have celiac, the intestinal cells can open up. That can allow other food molecules to absorb in, or gluten for that matter. The immune system attacks the gluten, and that immune inflammation can be associated with the depression, or the immune inflammation specifically can result in the peripheral nerves being attacked, such that people get numbness and tingling in their extremities, or they may suffer with lack of balance because the balance center in the brain is attacked.
And we've seen this dramatically in clinical practice. I mean, we've had some people come in and literally get off of gluten and have almost all of their neurological symptoms go away. That's more the exception than the rule, that dramatic of a response. But we've certainly seen it. We've seen it just in the last couple of weeks with one of our patients who literally couldn't even walk. And so, and it got rid of that, and we're just getting ready to, well, it did declare disability, but it can be pretty significant. The question of food intolerances versus food allergies.
So in essence, what they basically have substantiated now is that IBS patients don't have food allergies. You as the lay public out there have to understand that allergy is a very specific term within the research realm of medicine. Allergy refers to you eat something, there's a certain type of immunologic reaction that will cause basically lots of inflammation to go to the area. They're called mast cells. Histamine is released. Basically, it's this allergic nightmare. Think of, seasonal allergies in your sinus. Now think of that down in your gut. That's what's going on with food allergies, like a peanut allergy. Basically, with IBS patients, they find that that is not what is occurring, but there are still immunologic reactions occurring in the gut, as well as the fact that these bacteria, which we all have in our guts, which can be kind of disturbed in IBS patients, seem to really go into bloom, so to speak, with certain foods that we're going to talk about next.
And so if we heal that gut, the food intolerances many of them can go away.
In our clinical practice, we've seen that, yes.
And this is like the confusing, because a lot of people come in, am I going to have to be off these foods forever? And in the beginning, I really don't know. But so I can't say, but I'll usually indicate to them that if they have a gluten sensitivity or if they have a food allergy, there's a chance you may have to stay away from that for good. But this is the person that comes in to me and they have a food allergy test and they're allergic to like 56 different foods or 36, and you just mentioned maybe there might be 30 foods. And I'll usually tell them, you're probably not allergic to all those foods. You probably have intolerances or other things going on. We'll probably find out that that person is allergic to a handful of foods pretty severely. Would that be accurate? And then the rest of them over a period of 6 to 12 months generally will resolve, and that person can start eating those foods again. It's an important point for our patients because when they look at the diet that we start, they think like, oh my God, I can't eat this for the rest of my life. And they don't need to for the most part. So FODMAPs, you briefly mentioned FODMAPs, and more and more people are coming in today who have already tried the FODMAP diet. Let's first start with what FODMAPs are, and we can kind of walk them through why that diet works or why it doesn't work for them, and why even if it doesn't work for them, it may not be that's not the diet for them. I know that was a mouthful, but this is what we deal with all the time. This is the confusion we get when patients come in the door. So FODMAPs.
Yeah, that's well described. So
pretty
in essence,
cool name, FODMAPs. We should have come up with something like that. Power Health.
So they refer to fermentable oligo-di and monosaccharides, as well as polyols. And most of you are probably just glassy-eyed after I said that. In essence, these are certain types of carbohydrates that are in fruits, veggies, beans, wheat, dairy, that can result in the bacteria of our intestines having a party, in essence. So when we eat these foods in an IBS patient, these bacteria start to make gas and things of that nature, other byproducts. A lot of water can be absorbed into the intestines when these foods are consumed. And as a result of that, that can create the symptoms of distension that you may have in your abdomen, or pain, or bloating, or cramping, or constipation, or diarrhea, in essence. So FODMAPs are interesting because there are different FODMAP lists out there, and there's not a ton of agreement as to what completely constitutes a low FODMAP versus a high FODMAP. And so foods that contain a lot of FODMAPs, here's one list that we use frequently. The fruits that have a lot of fructose in them, which is one of the carbohydrates I mentioned, include things like apples, pears. I'm not going to read all of these, but then fructose sweeteners, high fructose corn syrup, which is in most of your processed carbohydrate goods like sodas and anything that's sweetened, pancake syrup. And then we have lactose, which is obviously from milk. And then we have fructans, or fructans, which are in artichokes, things that seem healthy like broccoli, Brussels sprouts, cabbage, eggplant, garlic, onion. Then we have fructans in cereals like wheat cereals. We also have fructans in watermelon. And then galactans are in things like beans and kidney beans. And then the polyols include apples and avocados and prunes and, again, cauliflower and mushrooms. So, and other sweeteners like sorbitol and xylitol. So this FODMAP issue can be significant for a lot of patients. And the recommendation is, if you have IBS, to go on a low FODMAP diet, where basically you eliminate those foods for 6 weeks, and then you introduce those foods back in one at a time. Now, we've had the luxury of doing this in clinical practice, and frequently patients with IBS and severe cases of IBS react to most of those foods again. And it creates a disheartening feeling amongst a lot of the patients, thinking, oh, I'm going to be relegated to being on this very restrictive diet for the rest of my life. Right. Now, I feel, have pioneered some ways to get around that by addressing the underlying causes of the problem. And we'll get into that as we go through this broadcast.
And you say, you have a number of statistics here that it looked like you wanted to share relative to patients coming in, patients getting on a FODMAP diet, feeling better.
Right.
Do you want to go through that?
Yeah, absolutely. So in essence, the early studies on FODMAPs, and FODMAPs were discovered in Australia. So they started studying this relative to IBS patients, and about 45% of patients with IBS improved on a low FODMAP diet. And then the studies repeated in America have been as high as 76%, where patients feel better on this low FODMAP diet. One of the criticisms is that we don't know the long-term consequences of a low FODMAP diet. We don't know what it does to the gut over 10 years because it's, again, a relatively new phenomena. But they've done studies where somebody will drink lactulose, which is a carbohydrate solution. And when they do this in an IBS patient, they can see that the distal part, which is the last part of your small intestine, will just swell and take on a bunch of fluid. Whereas in normal control subjects, they don't have that reaction. So that's everything I was talking about relative to fluid drawing in. When we ingest these carbohydrates for an IBS patient, gas will be produced. There have also been studies where FODMAPs help some people a lot going on a low FODMAP diet, and others don't seem to really receive benefit from that. And there are probably nuances in that, such that each IBS patient has a different profile. Some IBS patients are stress dominant. So stress can be a major player for the gastrointestinal tract, whereas others are more this bacterial issue. Others develop IBS after going on a trip and having an infection in their gastrointestinal tract. And then after that, they're never the same. So each patient is different.
Yeah, there's a lot of things that can cause that. Do you think stress causes IBS?
Absolutely, stress is
Yeah, we mentioned
unequivocally
that as one of the.
Oh, I didn't.
You
have that
briefly
down.
kind of, but it really, as far as what the underlying causes of IBS are, food intolerances, and I would say.
Oh, here we go.
I would say, it's on the next page.
Yes.
Sorry, and I would say chronic stress for sure. Chronic stress for sure. So we have a lot of patients that come in, and they kind of, by the time they get here, they've usually tried a lot of things, and they do the FODMAP diet. Maybe they've done one of the other diets, and for the most part, they'll feel better. Maybe they've gone gluten-free, and some may come in and say, well, I tried gluten-free, or I tried the FODMAP diet, didn't do anything. But most come in and say, I tried one of these diets, I felt better, and then I didn't. And now I'm confused, and should I be doing this, and shouldn't I not be doing this? And it is confusing because it's a little bit more involved in that. There are a lot of things that can be going on in that little intestinal lumen of yours at once. It's rare, and as Dr. Gates alluded to relative to the study that he was citing, that on the gluten and the non-celiac gluten sensitivity versus celiac and gluten sensitivities and so on and so forth. Studies are trying to isolate one entity in a very complex physiological system. And I would contend that most studies have to be flawed by nature, just in a sense of, if you're doing a number, if you're working on a number of human beings, one of the factors that doesn't seem to be taken into consideration is their stress levels. I never see that evaluated. And it's a huge factor in creating abnormal chemistry in the body and ultimately abnormal chemistry in the gut. Having said that, there are other things going on in there that may be sabotaging that patient who would do well with a FODMAP diet, but that have other factors that are going on at the same time that need to be addressed before that FODMAP diet can be effective and ultimately be found as to which of those food intolerances can and cannot be eliminated later on in life. So I'm assuming you're going to talk about SIBO. And
but I think that was a perfect description.
Oh, thank you.
It really is. No, because it's just not one thing. And everybody wants one thing for one condition. That is how we've just been drilled into in this society. You know, you're going to take a pill, and the next thing, your life is perfect, and you're running through a meadow with, you know, this wonderful partner of yours. Whereas that's just not the case with
I was just sharing.
physiology.
Yeah, I was just sharing with Dr. Gates that they've started a personalized lifestyle medicine course at Loma Linda University after years of telling us we're crazy. That's another name for functional medicine. And actually, my mentor apparently is on the board there. And then they're starting a personalized lifestyle CME course, 2 days long at Harvard now, as of June of last year. So this is starting to catch on. But my comment prior to us getting online was, man, what are you going to teach in 2 days? And then they're going to talk about stress. They're going to talk about exercise. They're going to talk about sleeping well. They're going to talk about nutrition. Right. You know, and this is the way we're looking. Okay, we're going to do this nutrition. We're going to use this diet. And that is not, you cannot look at a human physiology that way. It can't be done. But looking at it in this more complex and more realistic manner, really just doesn't fit into the research model, but it also doesn't fit into the clinical model of sit down, talk to the patient, find out what their symptoms are, do an exam if you're lucky to get an exam as a patient, and then ultimately prescribe something. You're going to get it. The next step out there is going to be very, very simplistic. And it's going to be somebody who's going to latch onto the FODMAP diet, who's going to latch on to getting off of gluten, who's going to latch onto this. And then when it doesn't work long term, which is going to be most of the time, then there's going to be confusion. And the reason it's going to be that it's not going to be a long-term success most of the time is what we're going to discuss right now. So let's talk about one of our
I want to say one
favorites.
more thing on that.
Yeah.
Just because we went to the International Conference on Human Nutrition and Functional Medicine, fantastic conference, wonderful speakers, Dr. Vasquez, he's a doctor of chiropractic, a doctor of osteopathy, which is, for all of you out there, it's basically a medical doctor. They do the same thing. Lots of times you see a DO when you're going to see the quote unquote doctor. And then he's also a naturopath. And then he accumulated all these speakers who were cardiologists and nephrologists and general practitioners. And I think there's
molecular biologist,
rheumatologist there, molecular biologist. Yeah. And they gave this speech. And by the end of Dr. Rutherford and I were sitting there and we were hanging in with pretty much everything that was being said. But when we talked to other members of the audience out in the foyer, so to speak, everybody was just glassy-eyed. They had no idea how to integrate this into their clinical practice. And I would foresee the same thing happening at Loma Linda or Harvard, because you just don't know where to start. And there's all this great information on the benefits of omega-3s and the benefits of 50 different vitamins for all these different conditions. But do you really want to give a patient all of that? We've been there. We've done that. It doesn't work. At least for the patients that we were doing.
And it's stressful.
And frequently made them a lot
when it
worse.
doesn't work.
Yeah, because you don't know if they're reacting to these supplements. And so this IBS topic is a beautiful example of that, where it's, you know, maybe it's not just gluten, maybe it's not just FODMAPs, it's not just stress.
My teacher at Harvard said it would work.
Right, exactly. Yeah. Have fun with that.
Yeah, so let's talk about the reasons that you went on a FODMAP diet and it either didn't work. I mean, it might not work because it might have been the wrong diet for you. Or let's say it's the right diet for you, but it worked for a while and then it stopped working. Let's talk about some of the other things. Having a party, as Dr. Gates put it, in your gut. Let's talk about small intestinal bacterial overgrowth, which we became aware of at that very conference that you just mentioned, and was a huge breakthrough for us.
Absolutely, for unequivocally.
Yeah.
So small intestinal bacterial overgrowth, referred to as SIBO, is now being demonstrated in gastroenterology to be associated with those who have a lot of bloating in their abdomen and belching, but it can also be associated with irritable bowel syndrome. SIBO, in essence, means you have too many bacteria in your gut. And the early studies on SIBO consisted of them going into the gut and basically looking at how many bacteria were in there. This is in siphoning out bacteria. The one thing you got to know is that, or one of the things you need to know is that we have a hard time culturing bacteria from the gastrointestinal tract because most of them don't grow in an oxygen-rich environment. So with these studies, they basically took a needle and took these bacteria out of these patients who had belching and bloating, and they saw that they had more bacteria than those who didn't have those symptoms. With that being said, that is not feasible to do in clinical practice, to go in and siphon bacteria out of the intestine. That's a very invasive procedure. So from that, they came up with this breath test, which we use in clinical practice, where a person drinks a solution of glucose or lactulose, which I referenced before as a type of carbohydrate, and then they look to observe how much hydrogen or methane comes back up out of the stomach, through the esophagus, out the mouth. And so it's called the glucose hydrogen breath test, or the lactulose hydrogen breath test. So that is how SIBO is diagnosed. But they're finding that there's this gray area where a certain number of IBS patients have SIBO, whereas not all IBS patients have SIBO. And then there are some people with SIBO who don't have any symptoms of IBS. So they don't have any change in their stools. They don't have diarrhea or constipation. And so the studies at this point say that about 30% of IBS patients have SIBO. The reason why this is important, because treatments targeted at SIBO we have found to be very successful for resistant IBS cases, or those who don't just have a food intolerance issue going on, or a gluten problem, or a stress issue. So that's really where the rubber meets the road clinically.
Okay.
And from that, we can go into rifaximin later on.
Okay. I was
And as
just
well
going to
as
say
other-
they have other ways of going about that. So if you're eliminating the sugars, essentially, all these FODMAP sugars out of your diet, and you're not feeling better, it might be because you have a small intestinal bacterial overgrowth there that needs to be handled. And we have a lot of stuff online on small intestinal bacterial overgrowth and where that can go. And it can go in a lot of different places. Those of you who can't lose weight, those of you who have insulin resistant, women who are growing mustaches, there's all kinds of places that goes. But relative to the gut, you need to get that handled. You can have an imbalance in bacteria. You can have dysbiosis.
Right, which is what we can go into next. So what they're finding with a lot of IBS, especially diarrhea patients, is that they have an overgrowth of segmental filamentous bacteria, which is this odd type of bacteria in the gut that lots of times can only be seen with an electron microscope. So electron microscopes are basically hundreds of thousand times more powerful than the human eye. And these bacteria kind of look odd, they look stringy, and there are a lot of them in IBS patients, whereas there are not a lot of them in normal control subjects. And we also find that in IBS patients, there's a lack of lactobacillus, hence the reason why you should take probiotics, because it's good for gut health. However, hopefully you're seeing that there's just not one solution for IBS for most patients. You can take probiotics, you may feel better for a little while, but it's not correcting the underlying cause.
Yeah, it's the same thing. If you're taking a probiotic, but you have all this other stuff going on in your gut, good luck. You know, if you take it, it makes you feel better, fine. It's not hurting you. And now we're starting to call
I will interject there. And so what they're finding with SIBO is that it can be bad for a SIBO patient to take probiotics because you already have too many bad bacteria in the gut. No, I'm with you though. I hadn't thought of that either. So.
Yeah. So, and now we're calling IBS, IBS-D and IBS-C.
And then IBS mixed when it's
and so, do you want to discuss the diarrhea versus constipation versus what they might be looking for?
So what they found
is IBS-D is IBS diarrhea and IBS-C is IBS constipation.
Right. So,
and they're diagnostically different.
Yes. So the IBS-C patient, in essence, they have a shift in their bowel habits towards constipation. We have found that those who have more constipation have more methane producing bacteria in their intestines. So possibly when a IBS-C patient eats a FODMAP, their bacteria have a party and produce methane. The problem with methane is that methane paralyzes the intestines. So that just contributes to the constipation. They found that when somebody's more constipated, their bowels move slower and it actually causes more bacteria to grow. And so it's a self-perpetuating cycle. With IBS type D, that's where they have more diarrhea. They have found that those with IBS type D have more intestinal permeability because there's a lot of inflammation and fluid in the intestine that results in the diarrhea. And they've also found that that's where there can be more segmental filamentous bacteria in more of the IBS type D patients.
So, and this is pretty clear, okay? I mean, I know not everybody out there is a biochemist or an internist or anything like that, but when we talk to patients, we let them know there is a very organized way of going through the bowel and understanding what's going on there so that it can be resolved. But you have to first kind of get everything in the box. You know, like what are all the possibilities of this patient sitting in front of us that could be going on in that gut? A good history is oftentimes the key. I do the gut exams here, and whether the bowels are moving, whether they're not moving, what areas of the bowel are tender and inflamed, and so on and so forth. They're very important. And then that coordinates with what is in the history, and you can pretty much make a diagnosis from there, or at the very least know which of these tests to run. And speaking of intestinal permeability that Dr. Gates just got done talking about, one of the biggest reasons people will go on one of the diets that you've seen online that's going to cure your gut, it's going to cure whatever it's going to cure, is the intestinal permeability. One of the reasons it doesn't work is the intestinal permeability that Dr. Gates just talked about. In fact, I would say almost more than anything else, people who come in and get on a gluten-free diet and it doesn't work, or a FODMAP diet doesn't work, or whatever, it works for a little part and then it doesn't work, is usually intestinal permeability, because you now are eating other foods that also are creating reactions, other food tolerances, developing other food allergies, and so on and so forth. But I'll let Dr. Gates go into that in more detail.
And basically, the studies have shown that those with IBS syndrome can have this thing called leaky gut syndrome, where we did a whole broadcast on it, but again, the intestinal cells start to separate. Food molecules can be absorbed into the bloodstream. The immune system starts to get aggravated against those food molecules. That can increase what are termed intraepithelial lymphocytes. It's just immune cells flooding to the gastrointestinal tract in order to help with this condition. And this may be part of the reason why you haven't gotten better. We see cases all the time where an IBS patient has tried everything, they have a leaky gut. We go in and we use strategies to improve the leaky gut. And believe it or not, there are medical ways of doing this. And once we retest the person, their symptoms of IBS have greatly improved. So it's very, very significant.
If we retest them and that's gone, then you'll notice it's improved, and they're going to stay improved once you understand the diet that you need to stay on to stay that way. And then the last kind of a ticking time bomb, or the last thing in there that's going to sabotage your effort to fix your bowel with a FODMAP diet will be stress. Let's go back to the stress, because I think this is a huge one. Dr. Gates and I kind of actually, before he got here, I was starting to get into the functional medicine, functional neurology aspect too, because for those of you who have never listened to us, I've got everything we talk about, it seems like. And so that's how I got into this. And one of the things that helped me a great deal was applying functional neurological strategies and exercises to help calm my brain down and to strengthen, in my particular case, my cerebellum and my frontal lobe. And it really made a huge difference to me. Calming a stress mechanism down is something that really, I think, is the most underappreciated aspect of chronic pain. And although most people get that their stress irritates their bowel, they're doing probiotics and they're doing FODMAP diets and they're getting off of gluten, but nobody's going after the stress, maybe short of getting on Xanax or Prozac or something along those lines. So why don't you discuss that? I think this is like monumentally important.
So we're meant to be stressed out for 15 minutes. And what we're finding is that a lot of us Americans are stressed out 18 hours out of the day, and even while we're sleeping, such that then we can't sleep when we wake up in the middle of the night. And stress has an effect throughout the entire body. So not only do we feel stress in our mind, but our heart tends to beat faster. We tend to send less signals to the gastrointestinal tract to digest our food. As a result of that, we don't make digestive enzymes. As a result of that, we don't make digestive secretions to help us move food through the intestines. So we frequently find our stressed patients will suffer with constipation because, in essence, peristalsis, which is the movement of food through the intestines, slows down, although it can be associated with some diarrhea patients too. So with stress, what critically happens in the gut is that the intestines become more sensitive to pressure. And as a result, when we consume a food, like let's say you eat your hot dog, and that hot dog and the bread and the bun and the mustard and the relish are moving through the intestines, then the intestines will have more pain when they stretch than they should. And stress is a critical factor in causing that reflex to occur. And so the medical approach to this is to put people on antidepressants, like tricyclic antidepressants or serotonin-specific reuptake inhibitors like Prozac, to help them with these, what's termed nociceptive sensitivity in the gut, which is basically your gut's more sensitive to pain. Dr. Rutherford and I have married our approach where we look
Thank you. That's where I was going with that.
Really looking at why the person is under stress and then getting their brain out of this stress response. Because a lot of people will come in saying, I'm not stressed. And then we do an exam and, their hands are practically dripping in sweat. And we look in the back of their eyes and their veins are ginormous and their blood pressure is up and they're not getting blood flow to their fingertips. Yeah. And they have objective signs that they're under stress all the time. Yeah. And that those same responses may be happening in the gastrointestinal tract where they're not even getting blood flow to the gastrointestinal tract at the right rate. And that has to be addressed for an IBS patient to improve. And we have found it to be futile to not do this because we've tried it. Yeah. And it doesn't work.
So if you're not in Reno, Nevada, which is where we are, sunny Reno, Nevada today.
Yeah, exactly.
And you can't get here, to have these things evaluated, you need to know that if you're trying all these things that are not working in your gut, and you're trying herbs, and you're doing the diet for leaky gut, and you're doing the reason may be stress, you may need to start accessing somebody who can help you to calm your basically kind of a fight flight. If you have fight flight, if you're chronically stressed, you can't go to sleep, your brain's going a million miles an hour, you wake up in the middle of the night, you can't go back to sleep, or you've been diagnosed with post-traumatic stress syndrome, or you've had some sort of verbal or physical or sexual abuse, which brings these types of stresses on and keeps them going. You need to go address that. You need to find somebody to help you address that, or nothing that you do to try to help your gut with herbs or botanicals or diet is going to help you long-term. It's not going to happen. So again, we're trying to bring the whole picture to you here. We start out and we're talking about IBS as it relates to FODMAPs, gluten, and rifaximin, and that's the way we want it here today. We want, okay, I'm gonna watch, and we're gonna see what our irritable bowel is. He's gonna tell me what the FODMAPs are. I'm gonna eat them, and it's gonna be good. It is a rare person for which that will occur. Okay, it's a rare person for which that occurs. And for those of you who are lucky enough to have that, you're very blessed. Now, the medical profession is kind of, and we're not anti-medicine. I hope you've gotten that. Those of you who've watched this for a while know that we're not anti-medicine. But as I just mentioned, the medical profession, after years of beating us up, are starting to embrace this. The Loma Linda courses and the Harvard courses are testament to that. But that model still tends to, let's just say they'll put you on a diet and it doesn't work, they're going to tend to defer to medication. That's just what they're going to do. It's not like a criticism or anything. That's the model. Okay, that is the model we have adopted in this country. Like it or not, that's the model. So rifaximin seems to be a drug that I keep seeing regularly in Dr. Gates's reports. Mm-hmm. So why don't you chat with them about rifaximin, where this is kind of the medical approach versus the herbal approach, and maybe you can compare those two approaches too.
So rifaximin is a non-absorbable antibiotic. In essence, when we take it, it just stays in the intestines. So most antibiotics will diffuse throughout the body. So if you have pneumonia, you want to get that antibiotic to the lungs, as an example. Rifaximin doesn't do it. It just stays in the GI tract. And that can be helpful for IBS patients because it can wipe out some of these bad bacteria that are either associated with dysbiosis, which is where we get too many basically bad bacteria, but the overall bacterial load is not that bad. Or with SIBO, where we just have too many bacteria. And rifaximin can help to correct both of those scenarios. And rifaximin is showing to be beneficial for IBS type D, even IBS type C, where there's too much methane. And rifaximin also helps the SIBO patients, as I mentioned. Now, as Dr. Rutherford alluded to, the medical approach oftentimes is just to jump to rifaximin. And in these journal articles, I don't know if they got attached today, I put like 35 up in my email, and hopefully we'll get them attached at some point. These articles frequently will say that the gastroenterologist is not really that well schooled in dietary approaches for the IBS patient. And so they're going to maybe jump to something like rifaximin. Rifaximin may work temporarily. Some say you have to use 3 rounds of it. In our clinical experiences, the rifaximin obviously works, but then if you don't change the diet and get the diet pristine, meaning the food intolerances is out of there, the leaky gut fixed, the FODMAP issue really sorted out, then it is an exercise in futility, and this person will just continue to suffer. After feeling better for a little while, they'll go back to their old habits and having pain, bloating, cramping, diarrhea, and constipation with their irritable bowel syndrome.
Okay.
So that's really the skinny on rifaximin. And then, lastly, they've done some studies where they give people probiotics and it helps them to feel better. But again, those studies are basically marginal, and it's not the end-all be-all solution for the IBS patient. And hopefully you have that by now. One last thing I'm going to say is that relative to the FODMAP issue, we have also found that pureeing certain types of carbohydrates can be really important, and FODMAPs may not be enough. There are other diets called the specific carbohydrate diet. Sometimes you have to include features of those. Sometimes you have to look at how much, for example, how many peas a person is eating or how much cabbage they're eating, because all these little things can be very, very significant to the chronic gut sufferer. And as much information as we tried to present today, I would say that's really about 25% of what we use clinically in practice on a day-to-day basis, because each gut patient is different. And even for you patients out there who suffer with ulcerative colitis and Crohn's disease, they're now finding that there's an IBS component to those autoimmune gastrointestinal diseases. And once you correct the IBS component, we even have a case of autoimmune hepatitis going right now. And our whole universe has come to center on her IBS, because when we help the IBS, all of our other liver enzymes come down and her gallbladder symptoms get better and her heartburn goes away. So that's really the story.
Yeah. So, so in the end, it's irritable bowel syndrome. We wanted to touch the FODMAPs because it's a common topic around here, gluten, rifaximin, but in the end, it's kind of a complex issue. And when Dr. Gates talks about this, we have a diet that we put people on. All right, it's not a magical diet. The diet is like everything we've ever seen somebody react to in this office is off the diet. So it's basically meats, some fruits, and some vegetables. It's a diet that they're on for a very short period of time, and then Dr. Gates starts evaluating them for these different food sensitivities. Why do we have so many different food sensitivities? I can only conjecture. I mean, it can be the stress. You have a complex physiology. So if you get stress hormones flooding your entire system, what are they going to affect? What are they not going to affect? Our immune systems are breaking down as we sit here. And it's a new development. And I can conjecture as to why that is, with the enormous attack on our physiology relative to our lifestyle changes, our inabilities to sleep, eating junk, going to sleep late, getting up early, too many drugs, frankly. By the time people get into this, we're not anti-medicine, but when somebody walks in here and they're on 15 major drugs, you think your immune system can handle that. And we can get into some other controversial areas, which I won't get into right now, but it's like an attack on us. And then we eat food from everywhere now. We don't just eat food, man. When I grew up in Trenton, New Jersey, it was kind of like, well, it was an Italian neighborhood, so we ate a lot of pasta. Okay, but we weren't eating stuff from India, and we weren't eating sushi. I mean, that didn't exist. We weren't eating Indian food. We weren't eating Thai food. We weren't eating all these different types of foods. You know, there's just an instinct. I was going to say gut instinct. There's the gut instinct that, that our systems have to develop over a long period of time, and we have to get used to things. And I think our systems are being exposed to too many things, stress-wise and environmentally, but more food and these types of things. I don't know, but that's kind of what makes sense to me. But the bottom line is there's not one diet for everybody. And the bottom line is that our guts are so attacked today. And when Dr. Gates talks about pureeing foods, he's talking about some of the people who come in here who already they just can't eat. Their gut is so bad and they've lost weight already. And we don't need to put them on a diet where they're going to lose more weight. And so the uniqueness of his approach is really, as he puts it, it's a novel approach. It's a new approach, and it's working we have 2 or 3 people right now that, oh my God, they're so bad that they just they couldn't eat. And you have to take it on the lowest gradient. All I'm trying to do is make the point that almost when it comes to anything in chronic pain, there's no silver bullet. And when it comes to the intestines, and when it comes to the large intestines and the small intestines, and it really is so individualized. It's hard to even describe, which is why you can't get discouraged. There is a way. It's rare that we have a patient who doesn't get through it and get well. We've even had severe Crohn's cases do well, which you can look that up. Okay, so it can be done, but the way that it is approached out there is what I call an nibbling. People are nibbling. I'll try this. I'll try that. I'll try this diet. I'll try that diet. I'll try the antibiotics. I'll try the fecal implants, which we didn't talk about. We'll try this. We'll try that. That didn't work. This didn't work. That is a approach that for probably 98% of people is doomed to fail, just simply because of what we were talking about here. So really, that's what we wanted to bring to you, and a lot, and the specifics. Dr. Gates says that we went over maybe 25% of it today, but if you go back through this, if you have an irritable bowel syndrome and you're frustrated and you've been everywhere and you go back through this 2 or 3 times, I think you will have the framework of understanding why you are where you are, and maybe that will give you sort of a guide to where to start and where to go to, and those types of things. I mean, obviously, it is what we do. If you're interested, we're always accepting new patients, but we understand that most of you aren't going to come here or can't come here or whatever. So we're hoping that this data will help you to be able to understand yourself, maybe take a little stress off, maybe relax a little bit, maybe know that somewhere, somehow there is a solution for it. So, all right, so that's it. The bonus was you didn't have to look at us this week. All you had to do was listen to us. So next week we'll take that bonus away, and we'll probably be back on video again, and hopefully you'll join us next week for another topic that has some relevance to what you're interested in hearing.
Okay, thank you for watching, for listening.